G'day folks, my name is Martin Botha. This is the next drill episode, and we're going to cover infant CPR. We often forget about the little ones, don't we? Let's not forget about the little ones. So the adult CPR we focused on lots, but we haven't done much on the infant or the pediatric CPR. So the good news is that even though you don't see these kids often, the approach is virtually identical to the adult approach. And remember, the adult approach, the memory aid that I teach is you check for hazards, hello, hello, and then double A, B, double C, D. Let's do that again, double A, B, double C, D. So you first check for the hazards, then hello, hello. First A I'm teaching is A, he's not awake, or is he? You check if he's awake. Then the next A, if he's not awake, you activate immediately. So you activate the emergency response system, you go get the defib trolley. If you're outside the hospital, you go and phone, in my country, 112 on your cell phone, and you go get the AED. So to activate, a nice way perhaps of thinking about that is to activate the team and the toys. So the team would be contextually specific, depending on where you're at, and the toys similarly, because you're not going to call for an AED often in the hospital. Maybe you'll call for a manual defibrillator, but maybe you've got an AED in the hospital and that's what you call for. So you make it contextually specific and relevant. So check for hazards, hello, hello, he's not awake, and so activate the emergency response system, the resus trolley, the team and the toys. Then so double A, B, double C, D. So the B and the C then happen simultaneously, and so we're going to feel for the brachial pulse on the inside of the arm, on the pinky side, just above the crease of the elbow, the brachial pulse, as well as breathing. But remember, similarly in the adult CPR, you're not checking for a pulse, you're checking for a definite pulse. Why is that? Well, maybe you're not certain. Your adrenaline's surging through you, you're not certain whether there's a pulse or not. Give yourself 7 seconds. The book says 5 to 10, make it 7. So you'll check for 7 seconds, 1001, 1002, 1005, 1006, 1007. No definite pulse. At the same time, simultaneously, you're checking for breathing. And so you're checking for normal breathing. So that excludes, same as the adult, that excludes the agonal gasping. So if a patient's got agonal gasping, it doesn't count. So we're saying no definite pulse, no normal breathing. And we're doing that for 7 seconds, 5 to 10 seconds. So double A, B, double C, D. We've just done the B and the B and the C together, and we've said there's no B and C. So if there's no B and C, we start with circulation. Now for some of you, you might have been trained with the European Resus Council, the ERC guidelines. And the ERC guidelines says, well, in the child, because it's more likely to be hypoxic as a cause, well then start with the breaths. In emergency medicine, we often use this approach that we find the problem, we fix it, and we follow it up. Find it, fix it, and follow it up. So the European Resus Council says, well, if you found the problem, no breathing, then fix it instantaneously. And then they say fix it with 5 breaths. Wow, that's so interesting that from the same evidence, such a different guideline can emanate on one side of the Atlantic and the other side. So, and there's probably no real evidence for or against either side. We teach the American Heart Association thing that says no breathing, no pulse, and then start the compressions immediately. Folks, that's only going to take you about 15 seconds delay to the 2 breaths. The American Heart Association takes the approach, they say start something. And if you think about it, you probably haven't got this thing close by. And so practically, if you're going to faff around trying to find this bag and therefore delay the whole process, well, maybe that is the right thing to do. Just start something. And so we start the compressions instantaneously according to the Americans. If you've been trained in Europe and you've got this immediately available, there will be nothing wrong starting with the 2 ventilations. But we, in our company, we espouse the American Heart Association guideline, and so they say start the compressions. The Europeans, just one last comparison, the Europeans actually start with 5 ventilations, because they're saying if the cause is likely to be hypoxic, well then sort that problem out and sort it out properly. And so that's 5 ventilations prior to starting the compressions. So let's stick to the American Heart Association. Don't get confused. So we've checked A, the hazards. Hello. A, he's not awake. A for activate. Team and the toys. B and C straight away, same time. 1005, 1006, 1007. There's no B and there's no C. So instantaneously we start the compressions. Here's the internipple line. There's the nipples just a finger below that internipple line, and 27, 28, 29, 30. Immediately come here, the bag valve mask. If I'm willing and able, chest rises really nicely. 2 and 3 and 4 and 5 and 6 and 7 and 8. So I'm pressing really hard, a half to a third of the diameter of the chest at a frequency of about 110 per minute. It would be better if I've got a metronome, but my phone is recording, so I've got no metronome for you. 27, 28, 29, 30. 2 ventilations, 2 ventilations. If you look there, the chest is rising really nicely. Let's try and do it from this angle. So look at that technique. I'll try and show you there. I'm not manhandling that technique like that, the traditional CE technique. I'm kind of making my fingers more parallel, and more parallel on that rigid mask seems to work better for me. Use whichever CE technique you like. Can you see my 3 fingers here? E4, elevate. My little finger behind the angle of the jaw, lifting up, and this C compressing down. So C for compress, E for elevate, and not a massive chiropractic technique like that. Just a gentle sniffing position. Just a gentle sniffing position into that slightly extended position. Maybe you can put something under the shoulders. If you look here, there's a space under the shoulders, so this little child would benefit to get his airway into a sniffing position if I had something underneath the shoulders. C, E, and just a gentle ventilation. If these 2 fingers kiss, you've gone too far. It should just be a gentle little ventilation, enough for that chest to rise. Check it out, really nice, just gentle. Now look, I'm keeping my hand there. So if you can do that, really great, because then I'm minimizing the transition time. Remember, it's all about CCF, chest compression fraction. 27, 28, 29, 30. Come back here, and 27, 28, 29, and 30. Come back here, and so I'm trying to be off the chest for as little of time as I can. And so I want to minimize the transition time, minimize the time off the chest, but when I get here I want to ventilate slowly and gently, just enough for the chest to rise. If you can maintain this, great. If you can maintain it while the compressions are going. So what's going to be different? When that second person arrives, what's going to be different? Well, this person then comes in like this. And so the hands are kind of like that. Let me show you this way. There's the nipples just below the nipple line, and my compressions will be, let's do it this way for you, 12, 13, 14, 15, and then that person does their ventilation. So if there's two of us, 15 to 2, so that the transitions can be quicker, 12, 13, 14, 15, that person ventilates. So the coordination needs to be a little bit better between us to be able to get that going. So that's nice and easy. Double A, B, double C, D. A, he's not awake. A for activate. B and C, assess B and C at the same time. No B, no C. Then do C and D. What is that? Compressions. And then the defibrillator must come. Talk about the defib in a second. So maybe you haven't got one of these. Maybe you don't see kids at all. But maybe we might see a little child now and again. So it behoves us to know a little bit about these things. So any bag that we use, remember when we check it, you check the bag by once with pressure and once with flow. Checking once with pressure, no leak. Once with flow. This little pediatric bag has also got a pressure relief valve. Let me just get a bit closer. It's also got a little pressure relief valve there. This one says 35 centimeters of water, and then it says lock. So I've opened it here. Just show you there. I've opened it, and now it pops off if the pressure exceeds that 35 centimeters of water. Keep that open as a default option all the time. Keep it open. Why? Well, to prevent barotrauma, to prevent gastric insufflation. But be quick. to push it down half a turn and lock it. Now it doesn't blow off anymore. Be quick to do that if the chest is not rising. If the chest is not rising, then we need more pressure. Maybe you can discuss in your teams, what have you changed this ventilator to now? Is it a volume ventilator or is it a pressure ventilator? It's in one mode when I do that, and it's in another mode when I do that. This is a ventilator after all. So if you change that, then you can give the required volume at whatever pressure is required. There's the answer. So if the patient's got bronchospasm, got some obstruction, got decreased compliance from whatever reason, well, then you'd be able to get the amount of volume in. This is a really small one, and it would only be okay probably for maybe the first month or so of life. And the slightly bigger pediatric one, can you see the difference, has got a little bit more air. Always use a bigger one than a smaller one, because you can put less in if needs be. You just have to just gently give a little squish if needs be. Folks, just to remind you, these bags, same with the pediatric, and remember we said respiratory, hypoxia, etc. are a major consideration in pediatrics. Don't skimp on the ventilation or the oxygen. But we can use that little reservoir, put that reservoir on the back there, and if you notice, there are two valves, extra valves on the back of that bag. Those two are safety valves. Listen carefully to what I'm going to say now. If this bag collapses completely as this bag sucks from this bag, let me say that again. As this bag releases, it sucks from this bag. It's demand and supply of oxygen. As this one sucks, it sucks from here, supply and demand. If this one sucks flat, this one pulls out all the oxygen from this bag, it goes flat like that. Well, then clearly you need to turn up the oxygen. And so we say, well, let's put some oxygen in there and make sure this reservoir stays partially inflated throughout the time. That's how you know how much oxygen to put on the bag. This reservoir must stay inflated throughout the time and never collapse. If it's collapsing, this demand is more than the supply. And that principle applies to any reservoir bag, even an oxygen mask that you've got on the patient's face. So, coming back to those valves then, those valves at the back there, can you see if the oxygen supply, where is it, over there, has run out, and this bag is flat, well then those two safety valves, there are two safety valves. And the way I remember it, if there are two bags, 1, 2, there must be two safety valves in between. If this one is too little, the one safety valve allows in. Allows what in? 21% oxygen, God-given oxygen in the atmosphere. That's if this goes too flat. If the oxygen runs out or the oxygen tube falls off. Conversely, if this is too full, the other valve allows out. What does that mean? Let's say you put this small bag at 10 or 15 liters per minute. That's too much. This one inflates really, really largely, and it doesn't pop because this other valve says if this is too much, it will vent out. So two bags, if you've got two bags, there must be two safety valves in between. One allows in if this is too little, one allows out if this is too much. So the next thing, just very quickly to share with you, before we do some of the choking, is that when to use this AED in this little child. Well, kids also have primary arrhythmias. It's not too common, thankfully. But you will they say probably one in 10 kids, from some registry data in the US some years ago, 1 in 10 kids will have a shockable rhythm at the beginning of the recess, and a few more will have a shockable rhythm at some stage during the recess. Probably 40 or 50% of them will have a shockable rhythm at some stage during the recess. But 1 in 10 kids will have a shockable rhythm at the beginning. So that's not too often, but it's often enough for us to know about it. So if you've got an AED that's got pediatric pads, and that's the difference between that is just the size. And so if they've got pediatric pads, well then, as soon as you plug this in to the machine, power, pads, plug in, prompts, remember? Once you've plugged it into the machine, well then this AED realizes that this is a pediatric on the other end of these pads, and so it attenuates, it modifies, it it modulates the amount of joules, normally up to 50 joules, and then delivers that shock. If it's a small child like this, well, I'll have to put one AP, anterior posterior, and that's exactly where the picture reminds us to put those pads. If you've only got the adult pads, then use them. If you've only got the adult pads, use them. One anterior, one posterior. Remember, CPR saves lives is nonsense. Let's qualify that. In a patient with a shockable rhythm on the left-hand side of the algorithm, the left-hand side of the cardiac arrest algorithm, if they are in a shockable rhythm, well, then doing CPR by itself is a waste of time. You're deluding yourself. You need to add the defibrillator nice and quickly. And so even for these little ones, there could be some congenital issue, add the defibrillator nice and quickly. And so if you've got adult pads, AP. If you've got pediatric pads, up to 8 years of age, they say, 20 kilos or 8 years of age, these are the pads to use, because then you're giving the child the right joules. Here's a bit of interesting information that we share on the PELS course. Kids can tolerate, we start at about 2 joules per kilo. We go up to 4 joules per kilo, 6 joules per kilo, 2, 4, 6, 8. That's the dose to defibrillate, they tell us. But we can go up to a maximum of 10 joules per kilo, so don't be scared. If you're using the adult dosage, it's not a big deal. Kids can tolerate up to 10 joules per kilo. Don't exceed the adult dosage, though, clearly, in any child. So that's the defibrillator, and so if the patient needs to be shocked, then by all means add the shock to the sequence that you're doing. So that's the CPR and the AED, just a brief review. So have a look in your environment to see, do you have these things? If you don't have them, well, it still is incumbent on us to make sure we know these skills. It's part of our skills checklist on our global skills performance clinical skills checklists, and so that would be the skill in this drill that we need to assess. I'm just going to quickly demonstrate, as I just move the video just a little bit. I'm going to demonstrate the obstructed airway, because that unfortunately is quite poorly done. So here's a good way of picking up the child if you see that if you think that the child has got an obstructed airway. What kind of obstructed airway? A complete obstructed airway. So it's a clinical assessment. In the adult, we kind of looked at the person and said, well, are you choking? And we could get a response. If the person was saying yes, well, then they're not, right? In this little child, you're looking clinically. Is the child choking? Is he making noises? Can he breathe? Can he cough? If we hear nothing, take the child like that. That's an interesting way of doing it. Grab the chin, put your forearm right on the child, and just turn the child over onto your arm like that. And look what I'm doing as I just bring this video a little bit down. So now you're putting the child, that arm, on this leg, and then I'm dropping the leg. And let's just make it a little bit down. So I'm dropping the leg all the way down, putting the elbow to the side of the body, so I've got lots of arm on lots of leg. Folks, this is poorly taught. People do it in the air like that. That's crazy. This child's freaking out. He's busy dying. He can't get breath. He's dying. So you'll need to grab him, support him properly, put him down on your leg. Can you see I'm just sitting on the edge of my chair, lowering this leg so gravity helps me. And now this is something that's also poorly taught. The way we need to give the back slaps in this child for this complete obstructed airway is transversely, shoulder to shoulder. So it's straight away down like that. And 4 and 5, up to 5. If it comes out after 2 or 3, stop already. Otherwise, you're just abusing the child. But it's transversely. It's not like this. That is the wrong way. Don't do it like that. You're trying to do that to be able to get the back to the front. In other words, you're trying to increase that intrathoracic pressure. So go use the entire palm of your hand and go straight down. Then, after 5, if there's no response, sandwich the child to the other side. Check first. You need to check to see that there's nothing in the mouth. Otherwise, you're just abusing the child further. If it's come out, great. You'll take it out and you'll scoop it out gently behind the obstruction, not to worsen it. Then we do, same place as we did, the compression is just below the internipple line. So, up to 5 chest thrust, and you can hear that explosive expulsion of that air. So up to 5. Then you check in the mouth again. 5 back slaps, 5 chest thrusts. Sandwich the child around again to that side. And again, up to 5. And then again, have a look. See nothing. And up to 5 again. and that's the obstructed airway. So have some fun with that, practice, and remember that pediatric resus is if you intervene quickly and the patient doesn't become hypoxic, they've often got a better result. So get in there, practice it. You never know when you might need to save a life for a little one. It's the most precious life to save. So thank you. I hope you enjoyed that. All the best.